Welcome to the Heme Consults orientation video series. This is video number 22. And I'm talking about special consult requests, and this is from CT surgery. These are the ICU or the OR calls. And I have to tell you that I actually debated doing this video because I thought I've talked about surgeons 3 times now. I talked about surgeons, I talked about neurosurgeons, and now I'm talking about CT surgery. But I thought it was important because CT surgery is different because they have anesthesiologists who are usually the critical care attendings. So this is important to note because anesthesiologists manage so many drugs in the OR. They're not really afraid of drugs. They understand drugs. And so it's a little bit of a different thing when they call you, because usually when they call you, they're pretty clear about what they want. The anesthesia attending knows that he wants Novo 7. And this is why. This is what we would give in the OR. This patient is bleeding. This makes sense. So you want to think about that. Sometimes there's a clear sense of what is right, and they're not calling to ask for your permission. They're calling to tell you what they're going to do with your approval. And it's okay. Don't take it personally, though sometimes you feel like, but I'm the one giving the approval. Remember, you are not a gatekeeper. You are not a doorstop. You are a sleeper. You're a bump in the road, and you're helping them pause and think about it. Well, if it comes to the anesthesiology attending who's telling you, this is what we want to do, this is the way we want it done, your job is to say, I'm new, and it would help me to understand your line of thinking. Why do you think Novo 7 makes sense for this patient whose fibrinogen is 110? My thinking is that the fibrinogen should first be at least over 150. Please help me understand your thinking. Those would be the kinds of things where, no, it's not a battle about whether you give the drug or not. It's really about help me come to a place of understanding. And you really, to be honest, this is not just about CT surgeons or anesthesiologists. This works in general where it feels like it's becoming adversarial. You want to pause and say, it sounds as if it's getting like it's feeling as if we're fighting over this, but what I really am trying to do is understand. And that's always helpful because people are able to share their perspectives with you when it seems as if you're there to understand rather than thinking that you're there to judge them. So think about that, especially when it's the anesthesiologist, critical care doc that's calling you. It may not be the anesthesiologist. Perhaps it's a younger member of the team. You want to make sure that you just recognize also what the perspectives are. And if the younger team member may not be able to articulate it to you, you still do need to understand it. And so it might be at that point where you're like, can I speak to the attending? Not because I don't believe you, but it would help me to understand why you think this drug absolutely needs to be given right now. Okay. Now, HIT is a problem for which in general, they have a low tolerance threshold. These are patients who have major CT surgery. They're concerned. They don't want any patient to have major thrombosis. They have a low threshold for HIT. And so sometimes they'll call, you'll calculate the 4Ts. You'll say, but the 4Ts is 3. They're like, we don't care. We know the 4Ts is 3, but we're so sure the patient has HIT. Again, you're a bump in the road. And so you'll pause and say, well, in general, with a 4T score of 3, it's actually not even recommended to do the heparin PF4. However, you feel really strongly about it. Why don't we wait for the anti-heparin PF4 testing to help us decide where to go, right? You could start on bivalirudin. If negative, we go back to heparin. And those are the kinds of things potentially that you negotiate really to maximize patient care. And if for whatever reason it feels like it's turning into an argument, don't make it an argument. Just try to understand. And if you don't understand, document to the best of your ability in the chart about the risks and the benefits. Again, don't write in the chart and say, we said no heparin. It doesn't seem right to start a war in the chart. It's really about, we weighed the risks and benefits. In a patient with an anti-heparin PF4 score of 3, the likelihood of HIT is small, and there's increased bleeding risk in a patient who has thrombocytopenia. For this reason, it was our thought that heparin could be continued. However, the attending anesthesiologist felt strongly that HIT might be present. For this reason, we have agreed that an anti-heparin PF4 level will be sent, and if negative, the patient can go back to heparin. So those are the kinds of things that you might do to negotiate rather than feeling like you're a wall that needs to stop the approval. When in doubt, seek to understand. Sometimes there's a clear line of reasoning that just hasn't been communicated to you, and staying in curiosity, staying humble, allows you to elicit that information so that it doesn't look as if you're attacking or judging the decision. Okay, now outline a plan to reassess. So they're like, we really, really think it's HIT. We don't care that the results are negative. We really, really think it's HIT. We want to send an SRA. Okay, you may continue bivalirudin, and let's reassess when the SRA comes back. we didn't think the patient had HIT. If the SRA is negative, we're going to believe it. And so right in the chart, team has decided to continue bivalirudin because they feel really strongly that the patient has HIT. I've recommended that given these parameters, a patient likely doesn't have HIT, but let's see what the SRA shows. If negative, patient will be transitioned. So you're negotiating this whole time rather than trying to stop them from doing what they're doing. Okay. If there's a call from the OR, there's a lot of anxiety and worry in the OR. If they're calling you, it's not a happy reason. You do want to return that call in a timely manner. In the past, I've talked about you always have 10 minutes. You always have 15 minutes. You probably always have 30 minutes, honestly, on pages. However, when there's a call from the OR, it is fair to return the call as soon as possible and definitely inside the 10-minute window because things are evolving rapidly and they do want an answer quickly. That being said, don't ever feel rushed or pushed to make a decision immediately that you don't feel comfortable with yet. When in doubt, call the attending. So it may be that you don't have time to do the literature review to figure out whether it makes sense to give andexanet in the OR. Call the attending and say, these are the issues. I'm thinking this is the wrong thing to do. What are your thoughts? So that can help you speed up the process as well. But definitely return those calls from the OR in a timely fashion. And if you have to drop the call to go talk to your attending, clarify with them what's an expected time frame for returning the call, what's reasonable, so that they're not calling you every 10 minutes or every 5 minutes. Say, hey, did you talk to the attending? Did you talk to the attending? Clarify the expectations so that you can help manage them as well. Okay. And finally, I do want to talk about helping to manage expectations. So sometimes the teams will call you at 10 a.m. and they'll say the patient's about to be discharged and we need your recommendations as soon as possible. And you know you're not going to around until 2 p.m. And so you need to help manage their expectations and say, you know what, we're not going to start running until 2 p.m. We have a list of 7 patients. It's not likely that we'll have a final recommendation or get to your patient by 5 p.m. You want to help manage that expectation so they're not calling you all the time. Anyway, so that's what I wanted to share about thinking about requests that come from the CT surgery unit. Now, you're going to get drug approval requests from the CT surgery unit. You're going to get it. So you just have a plan. When they call and it doesn't seem to be consistent with what's in the literature, how will I respond? Will I respond in anger or will I have a measured response? And so it's just helpful to anticipate challenges that might come. You've probably had 1 or 2 conversations that have been difficult. How did you navigate those? How might they look different? Imagine if you had the opportunity to practice these conversations in advance. Perhaps they would be less fraught. I think they might be. All right, I'll see you in the next video.